Are we? Actually, we will go with Miss Manning for 5 minutes.
Thank you, Mr. Chairman. Mr. Scott, I represent Caswell County, a rural county in North Carolina that has only one pharmacy for the entire county, a small independent pharmacy that is family-run and is struggling to stay open because they make so little money on the prescriptions they fill. I understand that PBMs negotiate with insurance companies over how much patients pay for their medications at the checkout counter and also how much pharmacists make for the prescriptions that are filled. Generally, chain and corporate pharmacies have better buying power and receive better reimbursements from PBMs. Is that true? Do PBMs negotiate how much pharmacies get paid per prescription filled, and can independent pharmacies get paid less per prescription than the big chain pharmacies?
PBMs negotiate with pharmacies to incentivize higher quality and lower cost, and about 40% of pharmacies that are part of PBM networks on average are independent pharmacies, and that what we have seen, the data we have seen, is that often the independent is getting paid slightly more than the chain.
So you're saying that what I've read in articles that affect independent pharmacies is not true, that independent pharmacies get paid more than chain pharmacies?
On average, that's the data that we've seen.
So why is it that from 2003 to 2018, more than 1,200 independently owned rural pharmacies closed in the United States?
So the data from the Community Pharmacy Lobby, NCPA, actually shows that across the country there has been a steady increase over the last 10 years in the number of independent pharmacies. Now, I would recognize, and I think...
But not necessarily in rural areas.
That is across the country. And I think the rural question is the one to focus on, because oftentimes, not only is that the only pharmacy, it's the only access point of care for patients. And it seems, certainly for our industry, we believe we need to empower pharmacies to do more for patients, be able to practice at the top of their license. We experienced some of this during COVID, so that they can deliver more value to the patient, and as a side effect of that, develop more revenue stream for the pharmacy.
So if we had more transparency, we would be able to tell whether large chain pharmacies get more per prescription filled than small independent pharmacies.
That data is available. I guess what the point I'm making is we need to adjust the law to allow the pharmacies to do more for patients.
Okay, but that doesn't really go to how much pharmacies get paid per prescription filled. That's a separate issue. What you're saying is let pharmacies do more so they can make money other ways.
Correct.
But that doesn't really address the question of whether small independent pharmacies actually get paid less than large pharmacies.
And I'd be happy to follow up with you on the data that we've seen.
Okay, let me ask you another question. In your testimony, you detail a variety of services that your member PBMs provide beyond negotiating for lower drug costs. For example, you said that PBMs provide clinical support in the form of services to plan enrollees, provide internal clinical expertise to support business operations, and assemble clinical experts to evaluate drug therapies and make coverage recommendations to plan sponsors. Aren't these all duplicative services that simply add to the cost of our healthcare system? For example, when you say that you assemble clinical experts to evaluate drug therapies and make coverage recommendations to plan sponsors, doesn't the FDA already evaluate the safety and effectiveness of every drug before they approve a drug for use?
That is correct, and we're adding to that value proposition of what the FDA does. And oftentimes, the pharmacy benefit company, for a given patient, whom I think of my dad's experience at the end of his life, Alzheimer's, cancer, multiple doctors, multiple medications, doctors' offices not always communicating with each other, the PBM was able to act to see if there's going to be any problematic medication interaction for him as the patient.
The PBM does that, not the pharmacy.
Oftentimes, the pharmacy may not have visibility into every place that the patient has gone to fill a script or a medication has been prescribed.
And aren't doctors?
But the payer may.
But aren't doctors already evaluating which medications they want their patients to use?
Absolutely, we provide information to empower them. But my dad's cancer doctor and my dad's doctor who was helping him treat Alzheimer's at the end of his life may not be communicating across all the prescriptions that they're reaching.
I'm glad your dad had a good experience, but I have to tell you, when I was using an eye medication that I had gone through multiple trials with my doctor to get used to save my sight, and my pharmacy benefit manager told me I couldn't use that drug until I failed forward, that wasn't a good result for me, and people all across the country have the same experience. My time has expired. I yield back.
Thank you, Ms. Manning. And